I'm Dr. Robin Williams. I'm a board-certified pediatric hematologist oncologist, currently working at the University of Minnesota Masonic Children's Hospital in Minneapolis. And I am a pediatric oncologist who mainly sees children with hematologic malignancies. And so usually that means things like leukemia and lymphoma, so blood cancers. But that sort of opens up also to diseases that are cancer adjacent, and one of those diseases being Castleman's disease, and specifically in my patient's case, idiopathic multicentric Castleman's TAFRO subtype. In, sort of the biggest umbrella of Castleman's is that it's lots of different diseases. So, you sort of start at the top and it trees out. And so we have Castleman's that can be either unicentric, meaning only one spot in the entire body is affected, versus multicentric, in which the person has lots of different locations in which they are affected by Castleman's disease. This is a disease of immune cells. So a type of lymphocyte called B cells are typically what is, we believe, is sort of part of the driving process. And then within the multicentric patients, again, we sort of tree out. And then we have patients whose disease is caused by a virus, HHV8. And that's rarely the case for pediatric patients. That's mainly in HIV positive adults. And then we have the HHV8 negative patients. And those are the ones who have idiopathic multicentric Castleman's. And what's interesting from there is you can then branch out again to have patients with sort of this TAFRO subtype, in which my patient that I'm caring for had, versus patients who have the idiopathic multicentric Castleman's that is not specified in any other way. So it's very, like I said, it's this huge umbrella that sort of branches out as you define the disease a bit better. This is what is so tough about this disease. So, as I mentioned, there's a unicentric or a single lesion disease, and that one's pretty easy. You find this one spot and it's enlarged, and you see a doctor, and that comes out, and you get your diagnosis. By and large, it's pretty straightforward. For patients who have the advanced disease, the disease in which there's multiple locations involved, it's one, quite variable, and two, the symptoms mimic a wide variety of other disease processes. So, patients typically feel bad, so they can have fevers and flu-like condition, what we sort of think more of as constitutional symptoms, symptoms that are sort of making the entire body feel bad. Sometimes they have, again, this is in my wheelhouse, they have enlarged lymph nodes as part of the process, and lymph nodes enlargement happens with lymphomas, but then it also happens with this disease. These patients can have low cell counts, so our blood cells that circulate can be impacted by this disease. So we say they have cytopenias or lack of blood cells. Sometimes the organs can get enlarged, especially the spleen and the liver. And again, very nonspecific. Sometimes they have a lot of weakness. So David Feigenbaum is sort of the person who really has brought this disease to the forefront. He had it himself, the TAFRO subtype. He is a huge advocate and studies this disease, but in one of his original publications, there's this nice chart showing how this disease really overlaps with so many other diseases. So the symptoms that patients have for this are the same symptoms that someone might have with malignancy like leukemia, lymphoma, like the same symptoms that somebody who has a infection like Epstein-Barr virus or some other infection. And then also like rheumatologic conditions like lupus and rheumatoid arthritis and some extreme versions of those. So unfortunately, none of the symptoms for this disease are sort of diagnostic on its own. So I can speak from my own experience that, as I said, there's such an overlap with so many disease processes that you really have to have a lot of cooks in the kitchen to make sure that an appropriate evaluation is happening for these patients. My particular patient was so sick that he was almost immediately admitted to the ICU. He was needing blood pressure support, and it was unclear that if we didn't do something urgently, that this was probably going to take his life really quickly. So there wasn't any, in his particular case, there wasn't really any time to do a enormous diagnostic evaluation to really get to the bottom of it before we had to just do something to, as I've said previously, cool him down because his body was so inflamed. It was just nearing the end of his life if we didn't cool things off. And so that's what we did. Once you get a patient stabilized, then the diagnostic evaluation really has to, like I said, be a group of people who can sort of be really experts in each of those buckets. So we had a rheumatologist seeing him, a infectious disease doctor seeing him, oncology was seeing him, and then, and then the ICU was monitoring him, and having all of us there sort of saying, these are the things we have to check off first, rheumatology doing that, and then us doing our evaluation. The biggest thing for us is we were, with these enlarged lymph nodes that he had, we were like, is this leukemia or lymphoma? Because that can spark off a whole other hyperinflammatory syndrome. And so once that was ruled out, and then rheumatology started ruling things out, and infectious disease started ruling things out. It's interesting, like somebody just has to take the helm and just look at everything, do the 20,000-foot view of what's been done, and then start asking the questions of what fits and what doesn't. In my particular patient's case, he was originally admitted to our hospital in critical condition at the end of July, early August, and we were not able to get his diagnosis, his official diagnosis, until mid-October. That was with a lot of very invested people doing as many studies as we could, but it's such a mimicker of so many things that it just took us that long to get to the bottom of it. So the one thing that we sort of had dangling in front of us, I guess I would say there's two things right now. One thing that was dangling in front of us that really didn't become obvious until a little bit later was we immediately got a biopsy of one of his lymph nodes, and it did not show leukemia and lymphoma. And like I said, that is an urgent thing to deal with that can cause the symptoms that he had. So we were really reassured. But in hindsight, looking back, the description of the lymph node was not normal either. Like it had some features that in some contexts could just be, if it was a normal healthy child who had this lymph node come out, I would say that's probably just a reactive process. But like I said, in hindsight, now that tissue in the hands of the right pathologist absolutely gave us the diagnosis. And so I think seeing those features in the future, I would want other oncologists or other physicians to send off that tissue a little bit sooner, and I will absolutely in the future. The other thing is he was sort of globally inflamed, and by that we were sort of looking at markers of inflammation in not just his fever, but sort of markers of inflammation in his blood. And he had certain ones that were exquisitely high that again later, for rheumatologic conditions, it's this other cytokine that's typically high, and his was a little high, but not much for the rheumatology one, so it probably wasn't that. And he just had his IL-6 was through the roof. That is a feature of this disease, is incredibly elevated IL-6 is sort of the driving process of this. So, or we think so at least. So that's so interesting. So first off, this is typically a disease of 50-year-old plus people. And even still, I think in that group, it's still only like 3 in a million are diagnosed a year. And so the pediatric numbers is maybe only at best a tenth of that. So we're talking about a very incredibly small number. Unfortunately, so as a pediatric oncologist, we're part of the Children's Oncology Group, a consortium that runs research studies across the country to determine the best therapy for, rare diseases, pediatric cancers, so that it's uniformly treated across the country. And I would say even COG doesn't give us guidelines for how to treat a newly diagnosed pediatric patient with Castleman syndrome, and especially the patients with this TAFRO subtype that is so aggressive. So it really is individualized. So I had reached out to a colleague of mine that was at Cincinnati Children's who specializes in all sorts of hyperinflammatory syndromes. And he's the one that helped me get to the get to where I needed to be for the TAFRO diagnosis. And then he gave me some advice on where I should start with therapy. And then the same was true. I reached out to Dr. Fagenbaum as well as Fritz van Ree and some other folks in the Castleman's disease network. And then they again gave some additional recommendations, but it very much is case by case basis. Start with X. If X isn't working, go to Y, and so on and so forth. So I do think it's one of those things that I would hope that, in some, like, I hadn't seen a case of his like this in any patients that I had taken care of before him, and I haven't had any patients since then. But it's just so incredibly important to have these stories out there, because I think that that is what helps us when those of us who are in a situation where we know a patient's very sick, we feel like we're not doing the right thing for them. Maybe we haven't gotten the right therapy, maybe it's the right diagnosis, but the wrong therapy. Maybe we're doing the wrong therapy because we have the wrong diagnosis. And just the more people are talking about this thing, the easier it is for the next person who's not expecting the diagnosis to show up in their practice, will have a resource to go to.